Welcome to Medicine Grand Rounds today. It gives me great pleasure to introduce Dr. Tracey Henry, who will be giving Grand Rounds. Dr. Henry is an assistant professor of medicine in the Division of General Internal Medicine. She trained at Ochsner Clinic after receiving her medical degree at Georgetown and her MPH at Hopkins. She also completed a health policy fellowship at Georgetown. Dr. Henry is the Assistant Health Director in the Grady Primary Care Center and the Director of the Health Equity Advocacy Policy Track for GME. Within the undergraduate medical education system, she is the program director for the Emory MPACT mentorship program for students who are underrepresented in medicine. In addition, Dr. Henry is prominent as a policy expert and has repeatedly shown us what it is to walk the walk of being a physician advocate. She has testified before Congress. She regularly writes op-eds that you may have seen in the Atlanta Journal-Constitution and other newspapers. And she serves on the ACP Health and Public Policy Committee nationally. She's received multiple awards for her work that are too numerous for me to mention all of them here. Most recently, this year, she received national recognition by being awarded the Walter J. McDonald Award for Early Career Physicians from the ACP, recognizing outstanding achievement. Dr. Henry truly is a physician advocate and has shown us so clearly what it is to be there for our patients. And so I'm so pleased to introduce her today to talk to us about social determinants of health at the bedside and in policy. Thank you so much, Dr. Henry.
Well, thank you so much, Wendy, for that very warm introduction. It's a pleasure to be here this afternoon to discuss addressing the social determinants of health from bedside to policy. Our objectives: to be able to define the social determinants of health, describe barriers to addressing the social determinants, review some of our institution-specific initiatives for addressing the social determinants, and discussing policy recommendations for addressing the social determinants of health. A little bit about our practice for those of you who do not rotate through Grady or work here. We are the largest public hospital in the state, and Georgia is ranked 39th in the US for overall health and 47th in the nation for percent of population uninsured. Our practice primarily serves African American, Latinx, and immigrant populations who are predominantly resource poor and of low socioeconomic status. Our payer mix is, has improved as 30% Medicaid, 27% Medicare, and 24% uninsured. So like many Grand Rounds presentations, we begin with the case. We have the 50-year-old female with history of hypertension, type 2 diabetes, HFrEF, who admitted twice in the past month with a heart failure exacerbation and once for hypoglycemia. She is a widower and a mother of 3 and takes care of her aging parent. She works 2 part-time jobs. She returns to the clinic for a hospital discharge follow-up. So to the resident, what are the issues? Could this be ischemia? Could this be AFib with RVR? Could it be hypothyroidism or some other medical cause? We think all these things because this is how we are trained to think. But what else could be going on? Could it be food insecurity? Perhaps our patient, and I like to give our patient's name, so this Miss Jackson, perhaps Miss Jackson, who was adherent to her therapy, and she took all the insulin as she was supposed to and the rest of her diabetes medications, but because she was taking care of 3 kids, and she also had an aging parent, she made sure that they were fed first, and therefore there was not a lot of leftover for her, and she ended up with those with those hypoglycemic episodes. It also could be a bit of low literacy or health literacy. Perhaps she didn't understand that the mealtime insulin, if I were to skip a meal, not to take my short-acting insulin. Or it could have been the cost of treatment. There was no copay for outpatient appointments or medications. Perhaps she had a lack of transportation or an inability to follow lifestyle modifications because of her home situation. Perhaps Miss Jackson, she lives in an unsafe neighborhood, and so she's afraid to go for walks in the evening, or she doesn't live by any nearby parks. And it could also be housing instability. So getting to the root of the problem, America's social determinants of health. So this is a quote from Secretary Azar, and I like this quote because he says, social determinants of health is an abstract term, but for millions of Americans, it is a very tangible, frightening challenge. How can someone manage diabetes if they are constantly worrying about how they're going to afford their meals each week? And how can a mother with a son who is asthmatic really improve his health if it is their living condition that's driving his condition? And further, this could feel like a very frustrating, almost fruitless position for a healthcare provider who understand what is driving the health conditions that they're trying to treat, who want to help, but can't simply write a prescription for healthy meals, a new home, or clean air. So before we can get further into addressing the social determinants, there are some key terms and definitions that we all must review so that we can speak in the common language. What are these social determinants? Well, those are the conditions in the environments where people are born, live, learn, work, play, worship, and age. And they can affect a wide variety of health, functioning, and quality life outcomes and risk. And this definition is taken from Healthy People 2030 from the Secretary's House or HHS Department and Office of Disease Prevention and Promotion. And whether you take this definition or the World Health Organization or the CDC, they all pretty much say the same thing. And I like to just easily say that the social determinants are just all of those non-clinical factors that affect our health. And are grouped into 5 buckets that include education, healthcare access, neighborhood and the built environment, economic stability, and social and community context. But there's one particular social determinant that is not mentioned on this slide. And that's racism as a social determinant of health. And I like this slide from Dr. Gee in 2007, where racism is, he uses an analogy as an iceberg. And so what we see is the tip of the iceberg every day. You know, what we see in the news, the things that happen with George Floyd and Ahmaud Arbery and Rayshard Brooks, you know, any of the hate crimes we've seen, the microaggressions and the everyday insults that racial ethnic minorities and other marginalized communities feel almost every day. These are the things that we see on the tip of the iceberg. But really, however, the individual experience of racism are all those things, but really what is important is what's underneath that iceberg and what is driving all of that. And that's the broader foundation of systemic racism that is far more difficult to observe, but probably even more important with regard to shaping the well-being of our racial ethnic minorities. And so you might be asking Dr. Henry, so how and why does racism make people sick? Well, racism can hinder one's educational attainment. It can impede the ability for a person to seek gainful employment, followed by decreases in potential wages. And that can lead to a lack of access to health care. All of that leading to potential poor health outcomes. Other reasons why racism may make us sick is something that we call allostatic load or wear and tear on our bodies. And that's that stress load on our bodies that increase biomarkers of stress, such as cortisol and CRP. It can also trigger coping mechanisms. And coping trigger coping mechanisms that are maladaptive. And then some of those could include increasing our alcohol and tobacco use and other drugs. And there are also avoidance behaviors. For instance, foregoing certain medications or even seeking alternative therapies just to avoid encountering the bias that they feel towards providers to themselves when they come into the clinic visit. And so some examples of systems affected by racism. We have healthcare, we have housing, we have the criminal justice system, we have education, we have the economic stability wealth gap. We also have our neighborhoods in our communities. Do these sound familiar? Well, they should, because as you can see, these are all the social determinants of health. So that's what I mean by, and what many people mean by when we say that the social determinants of health are rooted in systemic racism. If you think about the history of the United States, we've spent 80% of our history within slavery or Jim Crow. And it wasn't to the end of Jim Crow and in the end of the 1960s that America, or for the most part, America was free. And so 20% of America has been free. But the rest of 80% of America, we're seeing the results of all of the different policies and the systemic racism that have been carried over from all of those different times. And so the impact of social determinants of health is pretty significant. If you look at this slide in the pie graph on the right side, our social determinants can contribute to 50% of our patients' health. And even some experts say 80%. So if you include the health behaviors, then that's anywhere from 50 to 80% of things that are done outside of the clinic visit that are affecting our patients' health. And as much as I like to say and think, and we like to think as physicians and other healthcare professionals, that what we do is really awesome and great, but really what we do is only 20% of what contributes to our patients' health. And specifically, those 30% of health behaviors that I previously mentioned are tobacco use and diet and exercise, alcohol and drug use. I like to highlight this particular study. This is from McKinsey 2019 Consumer Social Determinants of Health Survey. And this particular survey surveyed over 2,000 participants. And in order to be in the study, you had to be uninsured or be insured by Medicare or Medicaid or through the individual exchange. And what they found in this particular study is that 53% of all of the survey respondents were adversely affected by at least one social determinants of health. And the number one social determinant that they found that affected this population was food environment, followed by community safety. And further, what they also found is that if you had at least one social determinant of health, including food insecurity or transportation need or community safety needs, you were anywhere from 2 to 3 times more likely to visit the emergency department within the last 12 months prior to this survey. And so I bring that up because using the emergency department is obviously not the answer for primary care or seeking the healthcare that you need. And also going to the emergency department is also costly. And for instance, if you look at this particular slide and take a look at the black line at the top that represents the US, and the US spends approximately 17% of its GDP on healthcare, which means if you look at the top line and you see the huge difference between us and the rest of the industrialized countries or the OECD countries. And OECD countries are just those countries where we all work together to support each other for to stimulate economic growth and stimulate world trade. But if you look at America, we spend way more on healthcare costs. So you may be asking, well, if we spend so much on healthcare costs, are we at least getting really, really great healthcare outcomes? And our health outcomes are actually the lowest of the countries of OECD countries. And so if you take a look here, and this is from the Commonwealth Fund analysis in 2017, we have 11 countries. US ranks dead last at 11. In terms of care process, we do okay around 5, but in terms of access, administrative efficiency, equity, and again, outcomes, we rank last or next to last. And I brought that up because what's really important for you to know is that those countries that invest in social care also have better health outcomes and lower healthcare costs. So if you take a look here at the US, previously the darker blue bar, we were 9 a few years ago in 2010 when I looked at this similar analysis, and now we spend a little bit more and invest a little bit more in social care. So now we're, at 17. But as you see here, proportionately, the other countries have proportionally, they spend more in social care than the US. And additionally, when we were thinking about terminology and using common language when discussing the social determinants, you will hear a lot about moving upstream. And so if you start at the bottom of the slide, where we are actually downstream. Downstream are those things we do in the clinic visit. So that is providing clinical care. And it's also our medical intervention, such as a patient that comes in with asthma. They may have been affected by all the smog in their area, and then we give them, for instance, an inhaler. But moving upstream, what we want all the way upstream across the top, those are our laws and our policies and regulations. And so, in doing that, perhaps we would want some policies on reducing emissions and better, better urban planning, and so that we have less pollution in the air. And then midstream are those social needs that we try to address in our patients at the community level or with social workers or community-based organizations. And then further, an example using income, downstream would be if you had a patient with chronic diseases like Miss Jackson with hypertension and HFrEF and also with diabetes. If I would like for her to enter into a chronic disease prevention program, I have to make sure I can find one that's accessible for her within her income bracket. And so midstream would be referring her, linking her with a social worker to find assistance for her so that she can afford a program like that, or even getting her into a back to work program so that she can develop more of a trade and have better income so that she could attend a program like that. And then further upstream would be advocating for living wage policies. So why the hype right now? What is the hype around social determinants? And I can say, I've been learning about the social determinants of health for at least the last, 15 or 20 years, ever since I was a medical student. But, there is a new paradigm in healthcare where we must address these social drivers that I've been mentioning. And value-based care is more than just about clinical excellence. And so our move toward reimbursing health professionals for value instead of volume, or for outcomes instead of process measures, as well as benchmarks for total cost of care, are all because we have a better push for value-based care. And so what I mean by value-based care in terms of like total cost of care, for instance, myocardial infarctions, I care more about the patient's 30-day mortality versus did the patient have aspirin on arrival. And so that's a good example of what we mean by value-based care. And then we also have new value-based payment models like alternative payment models such as ACOs or accountable care organizations and patient-centered medical homes and Medicare shared savings programs. And then also there's more emphasis on reduction in social risk. For example, food and housing insecurity that have been closely linked to poor health. And what we've also learned is that patients that are clinically complex often have socially complex issues. So back to our case of Miss Johnson, who's our 50-year-old who came in with multiple comorbidities for hospital discharge follow-up after 2 readmissions for heart failure exacerbation and hypoglycemia. So, as a physician, we bore witness to the impact of upstream social determinants of health on her clinical presentation. Generations of unjust policies created these downstream effects. Simply put, just all the generations of unjust policies that were created, left over from slavery, left over from Jim Crow. These all led to all of the downstream effects that we are seeing. And so 30 years ago, she was unable to buy a home in a desirable neighborhood as a result of her federal redlining policies that restricted Negroes or foreigners from buying homes in A-rated neighborhoods. And also it's our community. It's our school systems. It's the grocery store, the public transit, whether or not she's able to take the MARTA, for instance. They suffer all from decades of disinvestment. And then her current community suffered not only from disinvestment, but also the financial challenges of finding a well-paying job in those areas. And so the cumulative effects of all those stressors, all those years of disinvestment and generations of unjust policies have all led to what she's experiencing, combined with systemic and institutional racial biases, and that all contributed to her poor health and where she is today in your clinic visit. So what are some barriers to addressing the social determinants of health? Well, we talked about what are the social determinants. We discussed why are they important. We know some common language, but if we're so aware of all these things, why are we doing more about it? Well, some of the barriers could be lack of awareness for some and knowledge, lack of financial resources to address it once you know about them, the time and competing demands in the clinic visit or on the wards, and then, confusing terminology or the health professional's perception of what a patient needs, followed by the medicalization of the term social determinants. And then, will this be more clicks for me in the clinic visit, right? That is super important as well. If I'm going to do more work, is there going to be more things that I have to document? And so I like this particular study. It's from JAMA and it's from September 2019. And they surveyed over the study, investigators surveyed over 2,100 physician practices and over 700 hospitals. And they found that 1 in 4 hospitals and 1 in 6 physician practices screen their patients for social determinants of health. And I can say, well, that's good. At least it was 1 in 4 hospitals and 1 in 6 physician practices. That's a step in the right direction. But, then they wanted to know, well, why aren't you screening for those who aren't screening? And some of the barriers were, number 1 was lack of financial resources, followed by lack of time. And I like that some of the ones that were less of a barrier, like lack of knowledge and lack of incentives, I like to say that this is a great thing, right? Because we're an altruistic profession, and that is not it's incentives that is keeping us from screening, but it's more so the lack of resources for our patients and then lack of time. And most experts would say that, it is really unconscionable to screen for someone for the social determinants of health and not have resources available for them. And so another barrier would be, is it social determinants or is it influencers? So really sort of confusing terminology, social drivers, unmet social needs. So it's social something, right? And so sometimes that seems to confuse others. And I like this statement from Dr. Simon from Kaiser Permanente, Washington, and Health Research Institute. He said this in 2017. The word determinants does not allow for resilience, hope, or effective interventions. Some people defy the odds, and there are sometimes things that healthcare can do to improve the odds. So basically what he's saying is that the word determinant sounds like it's bad outcomes for the patient, and that they're sort of just stuck with that, and there's no way to change because they're determined, they're destined, so to speak. And so he suggested, that we swap the term determinants for influencers. And so nothing is your destiny. And either way, I like to say that whether we swap the term or not, we don't want to get caught up in semantics, but what we really care about is, these actual social determinants, influencers, drivers, or needs that our patients are experiencing and really coming up with a plan to address them. But, there's something, or food for thought for you. And so another barrier will be the medicalization of the term social determinants of health. And what I mean by that is that it's a process by which personal and behavioral and social issues are increasingly viewed through a biomedical lens. And so basically we're making the social need a pathology. And, kind of an example of that would be social determinants of health as a benefits packet. So we actually, some insurance like Medicare Advantage programs, Medicaid, they're actually starting to add social determinants of health as a packet. And what I mean by that is they're adding a housing benefit for rent, which sounds great. But what happens if you lose or switch your insurance, right? Are you now homeless? And so adding it just as a benefit packet is not truly the answer, even though it is great for the patient at that time. Another example would be with obesity. So, with obesity, we defined it as a disease, which in turn, it emphasizes individual treatment rather than community-based or public policy prevention approaches. Because what perhaps the patient really needs is something more upstream, right? We need more funding, we need more parks, we need more, more gyms, things that are affordable for our patients, healthy living, literacy on what to eat, funding to purchase the right foods. So it's really a health and all policy approach, which I'll get to later in the talk, but it's not just saying the patient has obesity and then saying you need to do X, Y, and Z. So from the bedside, student and resident-led initiatives. And so I'd like to take this time to really highlight some of the awesome work that our medical students and residents have been doing to address the social determinants of health in the clinic setting. And so this first one is one done by a resident a couple years ago, and the goal was to explore whether or not the residents in their continuity clinic were screening for the social determinants of health, and if not, what were the barriers? And then the third aim was actually to compare what the residents thought were the top social determinants of health for their patients to what the patients actually said their top social determinants of health were. And this was led by Dr. Nicole Treadway, who's an internal medicine primary care track resident. And this was within the social medical medicine elective by Dr. George and also Dr. Tejani as well, or one of the project leads. And so what we did was the patients were given a printed survey and they were to fill it out while they were in the waiting room. And this occurred again in late 2018. The residents were given an 8 self-report multiple choice question, and it was an online survey. And we actually had a pretty good response rate of 55%. So 54 out of 98 of the residents actually responded. And in terms of patient responses, about a 30% or a third of the patients filled it out. So there was about 1,000 surveys, however, we gave out 3,800. And what we saw for the patient responses is that we identified 10 different social determinants out of that survey. If I draw attention to the top left, to the yellow-orange bars, the residents, when they were asked, how often are they screening, 77.8% of the residents reported screening less than half of their patients for social determinants of health during the clinic visit. And if you look at the bottom blue bar or bar graph, you'll see that greater than 70% of the residents reported that they needed more social work. So the barriers they had are the same barriers that were in the JAMA study. So I don't have time, followed by lack of resources. And then a third barrier of, I'm not sure how to effectively screen. And so we look at the resident responses of what they thought the patient's social determinants of health were, the top 3. And, we see lack of transportation followed by unaffordable healthcare, lack of health insurance, and housing instability. But when we compare what the patient's perception of what was most pertinent, social determinants of health, to what the residents thought. So number 1 was food insecurity for the patients, followed by number 2, lack of healthcare or lack of insurance. And so that was congruent with what the residents thought, followed by unemployment. And then the patient's 4th concern was actually social isolation, which was not even ranked by the residents, which is actually pretty pertinent now, given COVID-19 and a lot of the social isolation that we're seeing, and mental health, depression, and other mental health disorders we're seeing during the pandemic. So in conclusion, the residents were very excited. They were aware of the social determinants. They wanted to screen for them, but really what they needed was enhanced clinic resources and comprehensive screening program in order to help their patients. And so a second program I'd like to highlight is actually a student-led event. And it's an umbrella student-run volunteer organization. And the name says it all, it's Grady Healthy Living. And so it's promoting patient wellness through traditional teaching and health coaching. And so what is the need in our neighborhoods? I like to draw attention to our employment. So 14 zip codes within our neighborhoods where a fifth of the residents are unemployed. And also almost 3/4 of our residents in DeKalb and Fulton County report consuming less than 5 servings of fruit and vegetables per day. This is the health coaching team, and this is the initial pilot team back in 2017, 2018. The executive leadership is Dr. Stacey Smith and Dr. Bussy Jones. And so the goals of the health coaching program was actually twofold. So not only were they there to help the patients, but there were some educational pieces as well that the students benefited from. And so the program actually introduced our M1s, our first year students, to the social determinants of health. They were able to improve their ability of how to assess patient management of chronic disease. They were able to practice motivational interviewing. And then also the fourth year medical students, it was an opportunity for them for medical education and mentorship practice and being a peer mentor to the M1s. They developed a screening tool. And this is the tool here. It's a social determinants of health screening tool or a questionnaire to be administered to the patients in the beginning of a clinic visit. They also came up with a Grady Community Resource Guide. And so this is the one from 2018, where they basically put together all the different resources from across the Atlanta metro area that were relevant for our patient population. And then also other goals, they completed a pre and post survey and also reflections and interviews. And what they found was that at the end, not only were we able to help patients in their overall health, but we had 28 student coaches. The student coaches were able to, had the ability to define social terms of health. They had knowledge on resources on how to address the patient's social determinants. And most importantly, they had confidence in their health coaching abilities. So another way at the bedside to address our patient's social determinants is through leveraging tech, and that's by leveraging our EMR. And so we rolled out actually a few weeks ago the social determinants of health screen in our Grady system. And we use Epic, and this is a screenshot of it. So you can actually go to the snapshot section of Epic and then click on, you'll see this wheel, you click on social determinants of health. Then you can also click on food insecurity. And so this is one of the ones that we have resources for. And so therefore we are screening for that and providing resources to the patient. And this is just another screenshot as well. Now, if we are screening a patient and they have a challenge with 3 or more areas, this will automatically generate a social work referral to assist the patient in navigating the system and getting the help that they need. Now, you may be saying to me, well, I don't have Epic and I didn't have the medical student team to kind of put together all the resources for me so that when a patient needs it, that I can help them with it. And so, my answer to you is you can also look these up as well. So there are a lot of locally curated social services, and the same program that the students use, which is Aunt Bertha, I have that demonstrated here on the slide. So you can go to auntbertha.com. And for instance, if your patient says, well, I need help paying for my utilities, or I need help with temporary housing or for housing. And, I click on housing, which I did there, and search for short-term housing. And then there were about 65 programs available. There are some resources for long-term housing, but that's more so for older patients or those who need sort of a nursing care. But this can definitely get a patient off the street and get them started and sort of get them in the right direction. Another organization, which is sponsored by the United Way, and it's called 211. And so very similarly, you go to 211.com, you put in your local zip code, and I did the one for Atlanta, and they have a ton of other resources as well. So you can compare, what 211 has versus what Aunt Bertha has. And finally, another sort of bedside initiative that I'm working on, and that's addressing social determinants of health through research. And I am a co-investigator with Dr. Nicole Franks and Cynthia Wiley, and it's a team of, which is growing, but it's a team of about 24 of us. And we are looking at the characteristics of readmissions of patients with COVID-19 and their outcomes and what social terms of health are linked with these readmissions in these patients. And so this is actually a multi-site study. So it's all of the 4 Emory hospitals listed here, but also Grady is now a part of the hospitals that we will be conducting research with, along with the VA, Hillendale, and a couple others. So addressing the social determinants of health through policy. This is extremely important, right? Because a lot of what I said was we have to move upstream, and upstream is policy, law, and politics. And this is a perfect example of that. And this is from Dr. Castrucci, and this was from the Health Affairs blog. And he says, referring a patient with mold in his or her apartment to a tenant's rights advocate, or feeding a patient who needs food, or providing an on-site exercise program. All of those interventions, just kind of like I said before with obesity, all of those interventions do not address the mold in that patient's apartment, neighbor's apartment next door, or provide community access to healthy food, or availability of a low-cost exercise option. All right, so when you do the one-on-one thing, you're really only helping one patient. But what we really want to start thinking about, are national strategies, things that are upstream, policy, law, and politics that will trickle back down and have a grander effect for our patient population. And so one specific sort of policy action was in November 2010. And this was the Disparities Action Plan by the Health and Human Services. And basically they aligned their program with initiatives like Healthy People 2020 at the time. And their goal really was just to transform healthcare and health and safety and well-being of our nation. And sort of going forward for the next few slides, I'm going to give you examples of what states are doing and what different communities are doing in terms of their clinics and hospital systems. And basically the federal government gives money either to state programs or either to these clinic or these hospitals, and they're trying to figure out how can they address the social determinants for their population. And so they're given money, and the things is that they want to be able to show at the end of these demonstration projects, are we saving money? Are we preventing readmissions? Are we preventing ED visits for our patients, and are our patients healthier? And so this one particular one is called the Accountable Health Communities. And it was implemented in 2016 by CMS, and it was a new version of an accountable care organization. It was a 5-year program for Medicare and Medicaid beneficiaries. And so, it supported about a total of 44 different clinics. And right now there are 29. And there's actually one in Tipton, Georgia there. And so again, so they're effective if they reduce total healthcare costs, ED visits, and inpatient hospital readmissions. Another thing that you'll hear me say, and I've said earlier, and we've been saying this since the early 2000s, is that what we really need is a health in all policies approach. And what I mean by that is that it's not just a healthcare sector to solve all of social terms of health, right? We need transportation, we need housing, right? We need everyone, agriculture, we need everyone involved if we're going to address this big problem of unmet needs in our patients. And so an example of what I mean by social determinants of health, if we start here at the top left and follow this over, an example would be, worldwide, 1 in 8 people, their comorbidity or 1 in 8 deaths are linked to air pollution and exposure. And so in order to tackle air pollution and exposure to our patients that are leading to death, we need clean energy fields. So if you start in top left and just follow it over. So not only do we need that, we need better ventilation in our homes and better construction standards. And then, if you keep right, we need to replace all of our smokestacks and improve our waste management systems, followed by low emission vehicles and better urban planning. So you have to work with those and more compact, sometimes efficient housings in certain places. And then moving over again to controlling all of our emissions from our waste management, to working with our local authorities on planning codes and tax incentives. And then finally, once you've been through all those other systems of housing and urban planning and transportation, agriculture, then we end up in the end here at health. And so the health sector, which is us, we're able to drive all of these conversations within all of these sectors to make sure that we keep health at the top of everyone's mind. And then, like I said, everyone has their plan and policy for addressing the social determinants. And, the CDC is not left out as well. So the CDC has its health impact in 5 years. And, the way that they categorize their policy initiatives is that at the base of the pyramid are those interventions that have the greatest potential for impact on health because they reach the entire populations of people at once and require less individual effort. And so a particular example of that would be early childhood education. And then they move up the pyramid. Another example would be Medicaid waivers or Medicaid initiatives. And so these particular waivers, the Section 1115 waivers, there were projects in Oregon and Colorado that had showed some benefits in addressing the social determinants, followed by another successful programming in New York, California, and Texas. Again, another state innovation model. The goal was to integrate social determinants and provide, they were going to provide financial support to all of these particular states. And the goal was to make sure we could decrease costs, improve quality of care, and improve healthcare performance and outcomes of our patients. So another thing that we could do that is a federal sort of state initiative, but it trickles down to us, and that is billing. And so these are Z codes or utilization codes for Medicare fee-for-service beneficiaries in 2017. But basically, these are Z codes that we can use for any of our patients, whether they're Medicare or not. But Medicare actually took the time to do a study of their patients and see how often were providers using fee codes in 2017. And so these Z codes were effective with the implementation of ICD-10 in 2016, and the categories range from Z55 to Z65. Currently, there's about 10 different categories, and each category has different subsets. Anyone can document, so it could be the social worker, it can be the dietitian, physical therapist, it could be anyone on the team. And previously, there was a little unsurety about that. But as you think about it, the social determinants, remember I said, are those non-clinical factors, right? And so you're not actually billing clinical diagnoses, which means that anyone on the team can bill. Now, the reason that we want you guys to start billing for these is because we're able to track social needs of our patients. If we're able to track the social needs, we can also quantify what those needs are. So we can qualify, these are the needs, and then how many of our patients have these needs. And then there we're able to advocate. We're able to say we need X amount of resources and these type of resources for our patient populations. And so it's really important that we do start utilizing these codes. And again, in 2017, with the Medicare patients, once it was initially opened up, only 1.4% of providers actually started billing, which is really low, but I'd be interested to see, where the billing is now that there's a little bit more awareness of these Z codes. And here are some examples of these non-billable codes that one day may be billable codes. And, a few that we may see a lot in our patient populations are problems related to employment or unemployment, or discord with boss, threat of job loss, change of job, unemployment, or problems related to housing and economic circumstances, such as homelessness or inadequate housing or low income, or lack of adequate food and safe drinking water. And so all of these are examples of what we could be coding and demonstrating need for in our patient population. There has been some legislation that passed in 2018 when this current administration. So they basically gave $100 million to fund state and local projects that were meeting these rigorously measured outcomes and costs and savings. So basically, we're the same thing. We want to make sure that health outcomes are improving, healthcare costs are decreasing, including hospital readmissions and ED visits. This particular legislation called CIPRA was mostly in maternal and child health, and it also helped patients dealing with homelessness. Another act called the Social Determinants Accelerator Act was a bipartisan support. 25 million, it's not a whole lot, but anything helps that can show and demonstrate health in a way that we provide, or healthcare delivery, and change the way we provide health that might be helpful for our patients. So this one actually has not passed. A lot of that has to do with COVID and a lot of the funding. So if it, a lot of initiatives like this were not necessarily getting funded during the pandemic. And then so also the American Medical Association of Social Determinants of Health, they also support training, and the AMA actually appoints people to ACGME and LCME, and they have something called Accelerating Change Initiative, which is 37 partnering schools, and they also have a module on social determinants of health. And the Accelerating Change Initiative, actually Emory is one of those 37 partnering schools. And this particular study is interesting. And basically the study PI actually surveyed about 28 of those 37 schools that actually returned the survey. And given that there's someone from each of those schools that are represented as part of this consortium, that are considered a health equity person or social determinants of health person. So even though they had a representation from somebody from each school, and in that sort of expert content, they were asked, what priority does your particular institution give towards addressing the social determinants of health in their curriculum? And so as you can see, at least 6 of the schools said extremely high priority, followed by 12 of the schools. So pretty decent amount. 18 of the 28 said, yes, it is high priority or extremely high. So I would say, having these initiatives like this is super important to showing the importance and getting more of this sort of education in UME. And at that time, still only 10 programs said it's of low priority, but that was several years ago. So, I like to say that we are moving in the right direction in medical education. Also, at the same time, they asked the same question. So if it's a priority, what kind of priority is it? Is it like half of the different institutions where you offered education and curricula on social determinants of health in more than one course or module clerkship? And so that was pretty good. At least half are doing that. So it's, somewhere around in the curriculum somewhere. And at least a fourth of the schools even mentioned that their overall theme across the curriculum was tied to the school's mission. And so, some took it a step forward to say, not only do we have curriculum in every course or module clerkship, but they also some even had a theme across that was tied to the school mission. So I'd say, just by having policies supporting the social determinants of health and how important it is to teach it in undergraduate medical education, that more institutions are starting to teach it in a more systematic fashion. And then also organized medicine is also not to be left out of addressing the social determinants of health. So our professional homes, like the American College of Physicians, they actually published a position paper, a policy paper in 2018 on how to address the social determinants of health. I'm actually one of the contributing authors as well. And so they also say some of the same things. They recommend that we adopt a health in all policy approach, and also that social determinants of health should be in medical curriculum at all levels. They also support, adequate and efficient funding of federal, state, and tribal and local agencies in their efforts to address the social determinants. And that includes investments in programs and social services that have shown to reduce health disparities or costs to our healthcare system. And another thing, we think about the ACP was really known for patients over paperwork. They really want to make sure that we have best practices for our EHR, very similar to what we're doing in EPIC, that we're able to leverage data as a tool, but without having all of the administrative burden and so many clicks in trying to address the social determinants. And then also the Society of General Internal Medicine also came out with a position statement earlier this year. And again, they prioritize social determinants of health curricula, both in the UME and GME, and for CME. So for us as well, across all curriculum. And then they also advocate for health in all policies approach. But what I do like, additionally, what I noticed in this position paper is that they also advocate for health impact assessment. And so that health impact assessment will enable us to better understand the extent of all the different intended and unintended health impacts of all key federal policies. And so it's very similar to how the Congressional Budget Office has a CBO score to project the fiscal impact on all of its federal policies. So we'll have a similar score, like a health impact score, health equity score for all federal policies, and go through sort of that review before a policy is passed or implemented. And then finally, we have the National Academy of Medicine. They also came out with their policy compendium last year, and they had 4 or actually 5 particular goals, and the same: integrate social determinants, build a workforce, digital infrastructure, how we're going to finance it, how we're going to research and evaluate it. And I like the 5 A's. So they have this framework of how to approach the social determinants. And so if you use transportation as an example, the 5 A's would be awareness. So ask the patient about their access to transportation, or adjustment. So if the patient needs more transportation, perhaps we should reduce the number of the need of in-person healthcare appointments for the patient. So maybe not bring them into the clinic every time, or for that blood pressure recheck. Perhaps some of those things that we can do over the phone or through a telehealth visit, which we're doing more so now because of COVID, but maybe just adjusting the need of when and how to bring them in. And then assistance. So provide the patient with the transportation voucher, or provide them with a public transportation like the MARTA card or something. So giving them assistance may also help them get into the clinic and have the healthcare needs met. Another thing would be alignment. So if you have so many patients coming from a certain area with a certain need, like transportation, we should perhaps invest in community ride sharing for our patients. And then finally, the big thing, which is the more upstream thing, and that's advocacy. So that's working to promote policies that fundamentally change the transportation infrastructure within our community. And so finally, when we're moving from bedside to policy, we have to bridge health and social services. We have to move from a system of being reactive to being proactive, from a system that values acute care to one that values preventative care. And then we need a bidirectional care and referral system. And so it's not good enough for us to just hand out referrals to our patients over and over and over. We need, if a patient's at a job placement place, program, and the person there is noticing the patient said, well, I haven't been to a doctor in a while, I have diabetes and high blood pressure and I'm out of medications, that person should be able to say, hey, let's get you into the clinic, let's refer you into primary care and help you get a primary care appointment. And then also, building on existing agendas while making incremental changes. And that could be an example of what we're doing here at Grady. We have this Grady Healthy Living program. We're doing a lot of screening ourselves. And so that's an awesome way for us to build on what we have already to make change for our patients. And then, moving upstream or starting upstream. So we really need policy implementation to drive what we're doing. And so in order to have a policy implementation, we need a national strategy. We need a multi-sector collaboration, as I mentioned before, a health in all policies approach. And starting with our communities and enabling community empowerment and really leveraging data. Because we do now have the capabilities to discuss not only individual patients for population health, but we can also now map social risk geographically. And so recapping, we are able to define the social determinants of health, right? Those are those non-clinical factors that affect our patient's health. Some of the barriers are medicalization of the term, for instance, making a social determinants of health as a benefit packet like rent or housing benefits. It could be lack of time and lack of resource and competing demands in the clinic visit. We also reviewed our current initiatives that we're doing here at Grady, like the Grady Healthy Living Project. And then we discussed lots of policies, Medicaid policies, healthy community policies, all different infrastructures that are there, including starting to use Z code so we can better inform CMS of where the problems are and what our patients need so that we can get more resources to our communities. And finally, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Remember to vote if you haven't done so already. Special thanks to everyone listed here on the slide. My contact information. Remember, healthcare, not so easy. And now I'll take a question and answer.
I am happy to moderate the chat. And so please feel free to go ahead and put questions in there. And I hope that you're seeing the kudos that are going by. I think these are such important issues. And I think that as someone who as you do, cares for a patient population that has many issues of social determinants of health, I think one of the challenges is always that some of the solutions need to be, institutional, but they really need to be local. And so one example, for example, is housing in Atlanta. And you refer to some great resources, but it really depends on, local government making a commitment to housing and so on. How does, I'm sure so many people on this, on the screen right now would love to sort of be involved and help with solutions. Where do you start on some of these really crazy, difficult local problems?
Yeah, very good question. I always tell folks organized medicine is how I got involved as a medical student and seeing problems in the health inequities. And I started off doing a lot of grassroots, like our medical students just kind of working together. They have that HSTAT program. But if you want to even have a bigger voice, organized medicine gets you there. You pick your organization, whether it's the Medical Association of Georgia, it's the American College of Physicians, or the your local state physician society. That's how you really get involved and amplify your voice. I've had a lot of opportunities to do a lot of things at the Hill and work with legislators because of organized medicine allowing me sort of that opportunity. And the other thing is, the great thing about working at Grady's, we're right up the hill from the Capitol. So, a lot of times on my lunch break when they're in session, I will go up there and meet legislators and develop relationships over time. And then you'll be that voice, the person they count on when it's time they need someone to sort of mentor them or tell them, why should I go for this particular legislation? So it's really getting involved collaboratively and working with folks, pick an organized medicine group, and that's the way that you can amplify your voice.
I think you just made a really great point. I think people often think that legislators are not people that we may or may not be that we can approach, or that you need to be an expert in the area. And so often they just want to hear stories about what's really happening in real life. And so you can be an expert like Dr. Henry, but if you can just talk about patients, those are stories that can go a long way. Dr. Bussy Jones asks, how do you respond to folks who think that doctors should focus on clinical care only? How should we add this into our student or trainee curriculum? Should it be optional or required?
Well, thank you, Dr. Bussy Jones. And she probably already knows, I definitely think it should be required. It's one of the things I plan to advocate for speaking, and I'm a member of the AMA, and they do appoint the folks for LCME and also for ACGME, and it should be required. I know the pediatric residency programs at least have a part of an advocacy curriculum, and they are leaning towards now saying that health system science is a third pillar of medical education. So much of what happens to our patient happens outside of the exam room. And so advocacy, I feel like, is a part of our covenant with society. We have the knowledge. We know what our patients need. We know what they tell us in the exam room. And so it's really our job to speak out for those patients that can't speak for themselves. So yes, it definitely should be mandatory, and it's something that we should have both in UME and GME.
Fantastic. Dr. Hassan asks, as EHC incorporates EPIC into all its primary care centers, is there thought as to how to incorporate social determinant of health initiatives at Grady throughout Emory Healthcare?
Definitely. First, I would start with making sure we have resources, right? I always say, why screen and you don't have the resources. And one of the things I should have mentioned is Dr. Treadway is Nicole, our resident in her research time elective. We're working on a one screener. So the other problem that I didn't mention is that these long page screeners are asking patients to just revisit and relive all these horrible things over and over again, all just to say, I'm hungry and I'm homeless. Why should they have to prove I'm hungry and I'm homeless? So, one of the things we wanted to make sure is, perhaps one or another social determinant is more indicative or predictive of another, so they wouldn't have to do these long screening. And we're working on how we can validate something of that nature. But getting back to your original question, first, making sure that you have resources available and someone that is invested within the system, and that you have someone validating these resources. Because a lot of the resources are very temporary, they're grant funded. And so what we did in 2018, the students put together, a lot of it could be null and void because a lot of the funding could have been lost. So you need someone regularly updating it. And then number three, you need a really investment in social workers and patient navigators, someone that's available for our patients in a warm handoff. A lot of our residents are doing it and our faculty are doing it ourselves. So we may, 10 minutes, we're done with hypertension, diabetes, and the heart failure, but then the rest of the 20 minutes, we're doing social determinants. So we really need more investment in social workers to make sure that they can help our patients navigate the system. Because some of our patients can't read. I can print them out paper and how to call, but they don't have a cell phone, or a cell phone has not a lot of minutes. And so we need a structure where someone can help them navigate the system.
That's a great comment. Dr. Stevens asks, can you comment on differences in addressing social determinants of health between rural and urban populations? Are there different approaches and so on?
Well, I think the social determinants, they're all the non-medical factors. And so the approaches are still the same, right? They may have different things that are an issue, but if, looking at all the different education, economic stability, housing, you go down the line and assess the patient for what they need. So maybe urban may need one thing, rural need another. Do a needs assessment, talk to the people, go where they are, and then develop community resources around their specific needs.
And sort of a question that I have, there's a lot of talk about telemedicine these days, and how that could revolutionize healthcare in a lot of ways, helping with challenges like transportation and so on. But on the other hand, there are also, challenges with internet access. How do you see telemedicine fitting in within the social determinants of health? Do you see that as a good thing, a bad thing?
Oh, it's definitely a good thing. There's some downsides. I bring one. I'm very much also a mental health advocate and mental health policy. I remember hearing some people say, well, it's helpful if the patient has a room that's quiet now during COVID where they can talk about sensitive issues. If not, then they're not going to talk about it because telehealth and everyone's listening to your business. But overall, in general, telehealth is good for both patients and the providers, because providers, there's more flexibility in schedule. Maybe you can extend more visits out over the weekend, which is helpful for patients. Our case of Miss Jackson in this presentation she wouldn't have to take off work to come in or find childcare. So it's a good thing for a lot of people. It doesn't replace the in-person visit, but it can certainly bridge some of those services and time in between visits.
Great. Well, we are at the top of the hour. So with respect to your time, thank you again so very, very much for this really, really fantastic talk about issues that touch our patients in many ways and really truly affect health. Thank you.
Thank you. I appreciate it. Thank you.